Hi, Jordan. Thanks for talking to me today. Can I just ask you to introduce yourself?
Yeah, so my name's Jordan Kelly. I'm the GP lead for cancer for NHS Lanarkshire. I work as a GP partner and I'm also a specialty doctor in secondary care in a breast cancer specialty.
So we're covering sarcoma and primary bone cancers today. Can you tell me what is in the guidance and what's changed?
So the main thing to say firstly is that these are adult referral guidelines and there are specific guidelines for referral of cancer in children and young people. With the 2025 guidelines for sarcoma and primary bone cancers, there's a new section on clinical assessment to aid recognition and to guide initial investigations for clinicians who are encountering symptoms that may be suspicious of a sarcoma or a primary bone cancer. Because soft tissue sarcomas and primary bone cancers are extremely rare cancers, in 2021 and 2022 accounted for less than 1% of new cancer diagnosis, it's really important that we have a tool and some guidance that allows our referrers to make appropriate referrals via the urgent suspicion of cancer pathway in Scotland.
If we start with the soft tissue sarcoma, what's covered in the soft tissue sarcoma section?
The assessment section regarding soft tissue sarcomas gives helpful advice about characteristics of lumps that may be concerning for soft tissue sarcomas. It includes features including a kind of rapid increase in size, a size of greater than 5 centimetres, the nature of the lump, whether it's deep, tethered, fixed, or immovable, whether it's hard, craggy, or fungating, or features which would be concerning for a suspicious soft tissue lesion, which requires an urgent suspicion of cancer assessment. For assessment of a soft tissue lump, which is concerning for a soft tissue sarcoma, referral via the local pathway on an urgent suspicion of cancer pathway would be appropriate. This might involve a direct referral to a cancer service or for an urgent suspicion of cancer soft tissue ultrasound scan.
So presumably it recommends investigations for lumps that don't fit those criteria.
So the guidance also includes some information on lipomas, which, as we all know, are not concerning malignant lesions. They're benign lesions which we encounter frequently in primary care and in secondary care specialties that don't require an urgent suspicion of cancer assessment but may require an assessment in secondary care nonetheless. But the guidance is very clear and helps to delineate between features of concerning malignant mass, which may represent a process like soft tissue sarcoma, and a benign process like a simple lipomatous lesion.
And then for the bone cancer section, what's covered in that?
Features which would raise suspicion of a primary bone cancer, persistent localised bone pain in the absence of another explanation. Other features which might support this would be persistent and worsening pain over a period of 6 weeks or more, pain which is there at night time disrupting sleep, or pain which is there at rest, or pain which can interfere with activities of daily living. These would all be features which would be concerning for a malignant process. For bone cancers, investigation with bloods may be helpful: full blood count, renal function, bone profile, thyroid function, myeloma screen. But the guidance is absolutely clear that an urgent suspicion of cancer request for imaging in the form of an X-ray should not be delayed whilst awaiting blood results. The guidance also makes clear that a negative X-ray result or an X-ray result which doesn't prove to show a malignant bony lesion, if there's sufficient ongoing concern, a referral should be made via the appropriate local pathway for secondary care assessment.
The other part of the guidelines that is really helpful, I think, is the good practice points. What's included for bone and soft tissue sarcoma in this section?
So the good practice points have been expanded to include advice on soft tissue lesions, including lipoma, bone cancer risk, and particular risk factors. One of the points that the guidelines makes reference to is treatment for childhood cancer, and this may include cytotoxic chemotherapies like cyclophosphamide chemotherapy agents, and also previous radiotherapy treatment, which puts people at higher risk of developing secondary cancers, including sarcomas.
Is there any information on incidence and health inequalities in the guidelines?
There is evidence that supports that young adult sarcoma patients have experienced significant delays in getting a diagnosis. That's through misattribution of symptoms, multiple visits to the GP, whereas elderly patients are more likely to be referred more urgently for investigations. So there certainly is inequality of diagnosis in our sarcoma population.